Mahaba, and welcome to a brand new episode of The Doc is In, where Cleveland Clinic, Abu Dhabi's expert physicians and dedicated caregivers converge to explore the dynamic intersection of technology, compassionate care, and cutting-edge research to help deliver the best patient care outcomes. Join us as we delve into the transformative advancements shaping the forefront of healthcare, sparking conversations that bridge innovation with patient-centered excellence. My name is Derek Keddington, and I'll be your host for today's episode, brought to you by the Fatima bin Mubarak Center here at Cleveland Clinic, Abu Dhabi. Before we dive in, remember to hit like, subscribe, and turn on the notification button. For joining me for today's episode is Dr. Raffi Gurunian. I didn't say that right. How do you say it?
Gurunian.
Thank you. So Dr. Raffi is the chairman of the plastic surgery department at Cleveland Clinic, Abu Dhabi, and a professor of plastic surgery at Cleveland Clinic, Ohio. He actively partners with our breast cancer surgeons to perform breast reconstruction during the course of a patient's treatment journey. So we're excited to have you with us today.
Thank you for having me.
So today, for our listeners, we're going to talk a lot about breast reconstruction as it relates to breast cancer treatment. So from your perspective and your experience, why is breast reconstruction so important to patients?
Now, breast reconstruction, let me define what breast reconstruction means. We do breast reconstruction in the setting where the breast is removed for cancer, unfortunately. And in that case, there is a need for replacement of the breast. And by doing this, we help our patients to feel normal again, to feel complete again after their breasts are removed for cancer.
Sounds very important for the psyche of our patients and helping them get back to everyday life.
Absolutely. And there has been a number of studies indicating the positive psychological outcomes associated with breast reconstruction. Because women won't like the idea of waking up from the surgery with flat chest. And that's an intense psychological trauma for those women. In addition to having the cancer to deal with, and now dealing with a kind of incomplete body, they feel very adversely affected by this. So, therefore, breast reconstruction that we provide helps them get their normal life. Again, as I said, makes them feel complete again. Well, I think from that standpoint, we improve the quality of the lives of our patients by doing this type of procedures.
That's awesome. So from my understanding, there's generally two types of breast cancer reconstruction.
Absolutely. So again, basically, we speak about breast reconstruction divided into two major groups. In one group, we have implant-based reconstruction, which means in that case, we place an implant after the breast is removed to reconstruct the breast, or in some instances, we use the patients their own body parts. And most commonly, we get tissues from their abdomen to reconstruct their breast with their own tissue.
Okay. So let's talk about implant-based reconstruction for a minute. What are some of the pros and cons of implant-based reconstruction?
That's a great question. We see these types of questions all the time by our patients that we see in clinic. I would say that every procedure we do has some pros and cons, as you said. Implant-based reconstruction, as the name implies, it's an implant. It's a foreign body that we have to introduce into the system, to replace the breast. A majority of the patients would select this type of reconstruction because the recovery is faster. It's a more simple procedure to undergo, as opposed to their own tissue reconstruction, in which case the recovery is a little bit longer. However, that kind of reconstruction may be more suitable for a certain group of patients who would like to have their reconstruction to last longer. So longevity and the long-term outcomes has been shown to be much better in patients when we use the patients their own tissues from their abdomen or somewhere else.
Okay. So with the implant-based reconstruction, it sounds like recovery time shorter, but you are putting something foreign into their body. How long does generally speaking, how long does an implant last?
That's another great question. My take on this is as long as they don't have any problems with the implants, and as long as their soft tissues, the skin envelope, what we call, they get along with each other well without having major problems, then we tend to leave them in place. There's no strict rule on time when we have to change the implants, unless this is why it's important that they get periodic checks with us after the reconstructions are complete.
Oh, that makes sense. So when you're talking about the autologous transplant or using their own tissue for patients, you said generally it comes from the abdomen. Does that surgery a lot longer? How much more complex is
Yeah,
that for
actually, we do
patients?
this all the time here. We have become a center for these types of reconstruction here, Clinic Abu Dhabi. I'm proud to say that uh, we can finish these surgeries if it's one-sided in about 5 to 6 hours. If it's both sides, we can finish those surgeries about 8 hours,
Oh,
which
wow.
is a pretty good time for such highly complex procedures. And I have a team to do this. I have my colleagues within my department, and we work together simultaneously. One team harvests the tissue, the other team prepares the site of the reconstruction, what we call, and then likewise, while we inset the tissue, and the closure is being done at the same time down in the abdomen. So therefore, we efficiently work in the operating room to cut the operating time as short as possible.
Oh, that's great. It seems a long time to me, but I'm sure it's not in the grand scheme of things. One of the questions I hear frequently from patients is the timing of these surgeries. So, are reconstruction done at the exact same time as the cancer surgery, or is there often a delay for
That's
reconstruction?
another wonderful question. Mostly, we would propose or offer immediate reconstruction for the reasons that we discussed. We don't want our patients to wake up with flat chest, with the psychological trauma that was created by removal of their breasts. Uh, and most commonly, we would place what we call a balloon, or what we say in medical terms, a tissue expander, and to temporize the situation until after their treatments are complete. And then we can come back, either we can switch that balloon, the temporizing device, to an implant, or we can still use their own tissue for a definitive reconstruction. But mostly we encourage our patients to undergo immediate reconstructions. Having seen those patients with no breast after mastectomy is really troublesome for a lot of patients psychologically, and therefore they're significant others too.
Well, that makes sense. What about when radiation is used for treatment?
Now that's something that we have to always factor into reconstructive procedures, because radiation adversely affects the reconstructive outcomes, whether it's an implant-based reconstruction or autologous reconstruction, because the purpose of the radiation is to kind of prevent the cancer coming back. But it's not as selective. So when it does that, it also creates some damage to the normal tissues. And our job is with normal tissues. And if we don't have
Mhm.
normal tissue to work with, then the implants cannot work properly. In those cases, mostly we would prefer autologous tissue. To bringing something which is healthy from somewhere else would make more sense in that situation, because again, implants and radiation therapy and adverse effect of it, they don't get it along with each other well. But that being said, I've had patients in whom we have done a temporizing device first, and then they had their radiations, and then two options. We can sometimes go to the implant-based reconstruction second stage, or we can just change the plan using their own tissue. But either way.
Sounds like it's actually a pretty complex decision-making process.
Yeah, absolutely.
Can you describe for our listeners and for myself, how do you involve the patient in this decision-making process?
That's another, there you're asking great questions. I think there's really no one option or technique that would fit to every individual. So therefore, the treatment should be tailored, or what we do is we tailor the treatment to the needs of the patient. So we do have breast tumor board meetings, which we hold weekly. And during those meetings, we discuss our cases. We discuss our patients, their presentation, the cancer presentation, if there's going to be a need for radiation therapy or not. What type of reconstruction are we planning to do in that particular patient? And all of those things we amalgamate and then discuss with the patient individually, and then come up with a treatment plan for that particular patient. And whether this could be, some patients would say, Dr. Raffi, I really should focus on cancer side of this. And I tell them like pros and cons of having no reconstruction. I want them to understand. And then if they're okay with it, sometimes there's no reconstruction, because there's so much going on at that time in those patients' lives, and we really respect that. And although I would not recommend, but we respect that. And we take a collective decision, and then we defer the reconstruction to another time, another date after the treatments are complete, which we call a delayed type of breast reconstruction rather than immediate type of breast reconstruction. Again, I think it's very crucial that here at Cleveland Clinic Abu Dhabi, we really listen to our patients, their desires, how to proceed, and we include them in the decision-making process about their reconstructive choices, explaining them the pros and cons of every step that we take, very frankly and openly telling them possible complications and risks involved as well. And the journey, my journey with those patients start with my first encounter after our breast surgeons called me about a patient. And then we sit, these first encounters are always a little bit difficult, because I have to break the news, what we can do, what we can't do. Yeah. And I tell them we're going to be friends, and we're going to become friends. The families will become, and it's a journey. And I kindly ask them to give me the liberty to slowly but surely work on their project to give them the best possible outcome over several months. Because mastectomy, as much as it's needed for breast cancer, it's kind of an ablative type of surgery, and reconstruction requires a little bit more time and effort to put it back together. So
sounds like you have a great relationship with your patients, and we're lucky to have you and other colleagues in plastic surgery with us.
Thanks so much.
And we have about 1 minute left. Is there anything else you want to tell our listeners related to breast reconstruction?
What I would tell them is Cleveland Clinic Abu Dhabi and plastic surgery, and we have a great breast cancer program. If they have a problem, God forbid, if they have a problem, they can knock on our doors, and we are privileged and blessed to help them to get their lives back, to help them improve their quality of lives, and make them feel complete with their families. I think that's what I would like to say at the end.
Well, thank you. And to reiterate what Dr. Raffi said, if you do feel like you need service here at Cleveland Clinic Abu Dhabi from our breast cancer plastic surgeons and their reconstruction efforts, feel free to click the link in the notes of the podcast below, or you can give us a call or visit clevelandclinicabudabi.ae. Thank you so much for coming with us today. It's been great to talk with you for my education, but also for our listeners. And for our listeners, hope you stay well and hope you have a great day.